So developmental dysplasia of hip is a condition where basically whenever we talk about developmental dysplasia of hip, there's 6 F's. Okay, so one is faulty carrying, female, firstborn, um, firstborn female, frank breech, fair, and family history. So whenever we talk developmental dysplasia of hip, it's a condition. It's a condition where the hip, where the acetabulum and the head of the femur, okay, acetabulum and the head of the femur, there's some anomaly. There's some anomaly because of which the head of the femur doesn't fit into the acetabulum, and it concurrently gets out. It dislodges out of the acetabular cavity. And there are different causes of this one. Okay, number one is, suppose, just think with me, just understand the concept well. If this is your acetabulum, if this acetabulum tends to become very, very flat, okay, like this. Suppose let's take this is, suppose this is your acetabulum here, and now the acetabulum is like this. Will the head stay here? Well, the head will stay here, but the head will not stay here, right? So number one is a shallow acetabulum. Number two, suppose the head of the femur is very small head. Can it stay? Okay, it can't stay. Number two is small head. Number three, whenever we talk about number three, see, suppose there is something in between these two, there is something. Okay, there's something in between these two. It doesn't allow a proper communication between the head of the acetabulum, the head of the femur and the acetabular cavity. And what is this something? This is known as interposed iliopsoas muscle. Interposed iliopsoas muscle. Because iliopsoas muscle are in close contact within this area. So interposed iliopsoas muscle. Okay. Next, number 4 is, what do we need to understand about number 4 is, there's a hypertrophy of the transverse acetabular ligament. Okay, hypertrophy of transverse acetabular ligament. Okay, TAL. Number 5 is, there is a constriction of the capsule. Okay, so there is a constriction of the capsule like this. Why is constriction of the capsule? Constriction of capsule in hourglass pattern. Okay, in hourglass pattern. So constriction of the capsule, and that will, if something is very hard, okay, very hard, that is constricting something, okay, proper communication is not maintained, right? So constriction of the capsule, and here sometimes there might be a lot of fat, okay, in between these two. This is known as fat pad excess. Okay, these are the different causes. Other causes are this one, the same thing, the 6 F's that I told you here. Now, a patient comes to me with a Trendelenburg gait. What is this Trendelenburg gait? Such a difficult name to pronounce, right? Just remember, sound side sinks. Normal, abnormal side lurches, deviates. Okay, the sound side sinks and the abnormal side lurches. Okay, the sound side, it just sinks down, and the body, it goes towards the abnormal side. Okay, the body goes towards the abnormal side. I'll explain you about this more in the next topic. Just understand about Trendelenburg gait. How will the patient of DDH present to you? The patient of DDH will present to you with difficulty in which of the movement? You can just remember, very easy. The patient's attitude will be flexion and adduction. Okay, so the patient, they cannot actually, there'll be difficulty in abduction. Okay, simply, if you understand, limitation in the abduction and internal rotation. So this happens in the case of Coxa vara deformity. and that happens in the case of skiffy, that happens in the case of congenital coxa, that happens in the case of DDH, and that happens in the case of DDH, skiffy, congenital coxa. Okay, there's one more, I just forgot this. Just remember that there are these pattern which is actually seen in the case of difficulty in abduction and internal rotation. Okay, now how are you going to assess a patient coming with DDH? Okay, suppose a patient is in my clinic who is less than 3 months, then I will just go for a Barlow test. Barlow test means I take my hands, okay, with at the side of the, remember, B for Barlow, B for bad test, because the child cries a lot. Okay, so I take my hands towards the child's hip, and then initially I adduct it, and later I abduct it. So I will show you this pattern. Suppose, okay, see here, suppose this is the acetabulum, this is your head. Okay, so whenever you adduct means the femur, the shaft of the femur, it goes inside, right? Whenever you adduct, the head comes outside, it goes inside like this, isn't it? But whenever you adduct from this adducted position, if you abduct, the head will go inside. So if you do adduction and abduction as one setting of test, you dislocate the dislocatable hip and again you relocate it. This is known as Barlow's test. If you talk about Ottolani test means already the hip is already dislocated, that this thing is already out, so you relocate the dislocatable hip. That is known as Ottolani test, done after 3 months. Suppose a child, he comes quite late. Okay, if he comes quite late, that means he comes after some time and it's very difficult to perform this test. You just go for a simple test. You can go for a Ellis test, Ellis or Galizzi test. Remember, Galizzi fracture is something different. This is Ellis or Galizzi sign, where you just ask the child to sleep supine and ask him to flex his knee. So on the affected side, the knee will be slightly shorter, like this, on the affected side. For unilateral DDH, you can do this for unilateral DDH. But if in case it's a bilateral DDH, what you can do is, you can actually look into a test which is known as, you can actually look into the x-rays, right? You can look into the x-ray, or you can actually go through Klissik test for bilateral DDH. Now, what is this Klissik test? Klissik test means you draw a line from your greater trochanter and your ASIS, anterior superior iliac spine, greater trochanter, ASIS, towards the umbilicus. Then what happens is, the head of the femur, it should lie lower and inner. Sorry, it should the umbilicus. Sorry, I am just very sorry. Okay, suppose this is your greater trochanter. You draw a line from your greater trochanter, anterior superior iliac spine and umbilicus. This line should intersect at the level of your umbilicus. The line through the greater trochanter and the ASIS passes through the umbilicus normally. Okay, but if it is below the umbilicus, if it goes below the umbilicus like this is positive Klissik test. Now whenever we talk about, okay, Klissik test, Ellis test, very good. Now we come to X-ray. So in the X-ray, what do? Is we just draw two lines. So perpendicular line is known as Hilgen-Wiener's line, and the other line that we draw is known as Perkins line. Hilgen-Wiener's line and Perkins line. The horizontal line is drawn through the inferior aspect of triradiate cartilage, and Perkins line through the lateral border of acetabulum. Okay, so if intersect this line, the femoral head, it should actually lie lower and inner, like this, lower and inner. Remember L, and you can write it like this, no? Lower and inner. I used to remember like this, lower and inner. If it lies upper and outer, this is a case of DDH. Finished. Simple. Hilgen-Wiener's line and Perkins line. Okay. Now we come to other parameters. You can also go for a USG. Where you will see the alpha angle decreases. Alpha decreases in DDH. You don't need to understand much more from here. Okay. You can also go for a von Rosen line. This is actually a view in your X-ray. Just know the names. The important one being the Hilgen-Wiener's line and Perkins line. Okay. Barlow's test, Otto-Lani test is important. Ellis test and your Klissick test is very, very important. Now we come to the management. The management portion I will discuss in next video. Okay.